Well, I'm Bob Phillips. I'm the Vice President for Research and Policy at the American Board of Family Medicine.
Andrew Bazemore, I'm the Director here at the Robert Graham Center.
And we're really pleased to be able to come to you today by high-def feed. We've been asked to address a certain number of questions that are really about the opportunity to learn from one country from another and multiple countries from each other as primary care comes into its own around the world. And wanted to give a little bit of history about how that's happened and that Andrew and I have been lucky enough to be a part of. So to begin with, Sue Dovey, who is now in Dunedin at the University of Otago, was an analyst at the Robert Graham Center when it started in 1999, and left here a few years later to go back to Australia and help set up the Australian Primary Healthcare Research Institute with Nick Glasgow. And it was a reintroduction to Nick Glasgow then a few years after that that set up a next opportunity for us to work with our colleagues in Australia.
And there's a real remarkable resistance to any lessons that come from outside our borders here in the United States. But nonetheless, I think the scholars on both sides of this relationship realized there was a rich exchange to be had. And we were really grateful when Nick helped us to create a primary care research fellowship that would send an Australian scholar, typically one that was recently graduated or recently exiting their registrar training, to the Graham Center to work on a shared scholarly project or collaboration. And there was considerable interest in some of the geospatial techniques that we had been using at the Graham Center and their potential application in a much richer, a much more data-rich environment in Australia, with a far greater emphasis on population health than we have here in the United States. So we began to exchange scholars. We're now on our 8th, but in the midst of this, we really developed an opportunity to meet a number of colleagues doing remarkable things in practice transformation on the ground in Australia, including Claire Jackson.
And so Claire Jackson and Carolyn Nicholson came to visit us at the Robert Graham Center, and it was right as the Affordable Care Act was starting to be implemented in the United States. And to their great credit, over breakfast one morning suggested that we had a lot to learn from each other as we'd both been through this period of health system transformation. And from that was born what we called APHCRI. That's the International Learning on Increasing the Value and Effectiveness of Primary Care, which our Agency for Healthcare Research and Quality and the Commonwealth Fund both supported. That brought together 7 countries to talk about and learn from each other about primary care innovations in their respective countries. That led to defining a package of transformational options and a policy roadmap. It led to a special issue of the Journal of the American Board of Family Medicine that featured the articles from each of the countries and a summary as well. It also, as I said, led to a policy transformation roadmap and a Commonwealth International brief that Commonwealth did not eventually publish but did accept. And the common themes out of APHCRI were that we had new models of care that we were testing out in each of these countries. We were very focused on quality and safety and improving both of those. That there were some innovative models of practice support and change facilitation in some of the countries that were helping speed transformation. That we were very focused on population health and accountability, something that was quite novel for many of the countries, including the United States. There were innovations in information technology and how it was being used and how it wasn't serving the needs of primary care in several of the countries. And then certainly around payment models that were needed to support transformation in each of the countries. And
this is a good moment to talk a bit about how Bob and I have personally been the beneficiaries of this international exchange and discovered, again, in our 3 trips now to Australia, that many of the methods we were working on here could be enhanced and enriched by the lessons we learned, again, in Australia. We've been building a series of tools that help to bring together population data with clinical data. And back in the early 2000s, this was it was somewhat radical, and yet incredibly poised to help inform the growth of the U.S. primary care safety net. The community health centers in the United States, built on notions that Sidney Kark and others in South Africa had borne, another international lesson, 4 decades ago, were perfectly poised to try to better understand the communities they served if they could only get their clinical data together with the rich social determinant data that's available through the U.S. Census and many surveys and health department collection efforts. And as we had begun building, again, both methods and ultimately online tools to allow this to happen, we had the good fortune of making a second trip to Australia and coming into two encounters that really helped shape some of our thinking.
One of those was with Peter Del Fonte around the health atlas that he was building in Western Adelaide, that was really doing a lot of the same work that we were trying to do and working very directly with clinical practices to make the tools more useful. We were also asked to help figure out ways of doing data connectivity in Australia so that the Medicare locals would have better tools and better support systems from their information systems to help inform their population health efforts. And it was in Perth that we actually ran into the canning extraction tool, another very important lesson for us, because while we've been asked to come over and advise on data connectivity, we suddenly found this tool that was being used by a third of the practices in Australia to extract data from electronic health records, and have brought back that idea to test in the United States, and we continue to actually work with the canning tool developer to translate some of those tools to a U.S. perspective.
So again, as an example of how 3 years later after this most recent trip, we're beginning to advance some of these binational, if not multinational ideas born of APHCRI, we are working with a state that has been very innovative in health systems change here, Oregon, to begin thinking about how you might take electronic health records and using some of the ideas that both Peter and the canning extraction tool we're beginning to advance in Australia actually allow clinicians, if not whole practices, to look at what we're calling community vital signs. How you might actually place not only blood pressure, height, weight, body mass index right in the hands of clinicians and administrators as they deal with patients and with groups of patients, but let them see actually where they live in the context of poverty, of food availability, safe water sources, walkability, and many, many other social determinants of health. And frankly, one of our favorite papers of the last 4 years, where we began to look at international ways of measuring social deprivation and tying that back to whether or not strong access to care would be available, again, for patients seeking primary care. One of these papers will actually, that was driven by a U.S.-Australian collaboration, will be one of the core indices that we'd like to put into practice and test whether or not it changes the interaction between patients and providers, between patients actually themselves and looking at their communities as they shape their health-seeking behaviors, and finally in practice-level decision-making.
Just as another example of looking for opportunities to continue to build those international collaborations, I was actually fortunate to get a Fulbright specialist position to go to the Netherlands to take some of the just geospatial work and population health measures work over there for discussion. And I came away actually with a much deeper appreciation of the integration of services on site in primary care that were happening in the Netherlands, and the value of having all of those resources available to a population in one place. It was really quite incredible. And really the lesson from that story for me was the need to look for other resources to allow us to continue to have this international conversation about what we can learn from each other. And so we're very appreciative of the work that Claire and others in Australia have continued to do in carrying this ball, carrying this idea of international collaboration around implementation science and innovation in primary care, with having now 2 successive meetings in Brisbane, and then having brought that meeting back to the North American Primary Care Research Group meeting last fall.
And again, now named the International Implementation Research Network in Primary Care, we see considerable opportunity, not only for our organizations, the American Board of Family Medicine and the Robert Graham Center, but for collaborators around the United States to benefit from being part of a broader network of primary care interested and policy interested groups, now 7 countries, hopefully going on many more, to really reshape practice transformation and systems level thinking that is informed by primary care lessons from around the world.
And our U.S. Agency for Healthcare Research and Quality, who attended that meeting, actually were so impressed that this conversation had continued 3 years after I Live PC, suggested that we actually bring some of those lessons back to the United States again, and we're currently in negotiations with the Commonwealth Fund to help support a series of embassy talks in Washington, D.C. that would bring Australia, that would bring the Danish, and would bring the Dutch back to the United States to have conversations in their own embassies with the goals of helping teach the U.S., again, about the innovations in these other countries, but also to be seen as experts in their home countries, and then to have a briefing in Congress for some of our Hill staff so that they might also learn some of these lessons. And that effort is also being supported by the American Board of Family Medicine and by the Robert Graham Center and its primary care forum function.
And we look forward to attending the next one of these events live and in person. We appreciate your taking time to listen to us today. And again, know that you're welcome at the Robert Graham Center and the American Board of Family Medicine if you're ever on this side of the ocean.
Thank you.